Hi, welcome everybody. Great pleasure to introduce Professor Pradeep Bhandari from Portsmouth. So, Pradeep, welcome to Endoscopy On Air. Thanks
Thank
for joining
you.
us.
It's
So,
a real pleasure.
Pradeep, we know each other since a long time. Is that true?
Yeah, I can't even remember how long, but
Oh,
it's
that's a
been.
problem. That's a big problem. So, we'll say it's a couple of years at least.
Oh, well, I would say almost couple of decades now.
Okay, terrible, terrible. So, Pradeep, how is going in Portsmouth right now with endoscopy? Everything is restarted or?
Well, yeah, the COVID brought a lot of things to stand still, but we are rapidly picking it up and we're working flat out 7 days a week and also in the
Seven
evening,
days a week.
7 days a week and evenings.
Wow, that's great. So you do not have a big backlog.
We still have a big backlog. So
Okay.
we're catching up, but we still have another about 800 colons to catch up.
Hmm.
The thing is, bowel cancer screening stopped for a year, and
Hmm.
that's a lot of colonoscopies that need doing. So I think our biggest problem is all the surveillance stopped, screening stopped, and we are catching up with all
So
those.
you also saying that you stopped the surveillance of Barrett patients?
Well, yeah, absolutely. You're right.
Wow.
Almost all Barrett surveillance stopped for, I
So
would say, a
regardless
year.
of the grade histology.
Yeah. Well, this is strange.
Hmm.
So I have a long waiting list for ESD and EMR because of anesthetic capacity, theater capacity low. During COVID, because theaters were not being used, I had free access. So I increased and doubled my capacity for resection of Barrett's, ESD, EMR, all that. So I caught up with all that backlog. But surveillance, screening, all that stopped completely. So they are really building up now.
Wow. So, Pradeep, you have been working in the Barrett space since long. You have published a couple of outstanding papers in the field. Also, I do remember a nice classification. Can you talk about your classification, the Bing classification about Barrett?
That's Thank you. Yes, Barrett's has always been a passion of mine. One of the earliest
That
things.
there was an Indian patient, I must say, because Barrett is not a big issue in India, no, in Indian
No,
population.
no.
So it's just related to your UK
Yes,
movement.
after I came to UK
Okay.
and saw this Barrett's, I was fascinated that how just a change in the lining, can make a person so much predisposed to neoplasia.
So
And
what is your thought about this big difference? So in UK there is a high number of Barrett, high number of patients with dysplasia on Barrett as compared with southern part of Europe. Is it just a matter of genetics or behaviors, alcohol? What do you think about this?
I think probably it's a combination of all this
Okay.
genetics as well as lifestyle. And I think when you have lifestyle which allows obesity to go up, increase lifestyle which encourages reflux and genetics, all these three together results in this because we see even in Asian patients living in UK or born in
Hmm.
UK of Indian origin, they've started getting Barrett's. So
Wow.
I don't think it's pure genetics. I think it's a
It's
combination of all
combination.
these things.
Okay. So back to endoscopy, to the classification. So can you
Yes.
tell us about classification?
So, back in 2006, I went to Japan mainly to learn ESD. But then I went to Saku and saw doctors using acetic acid after doing gastric ESD to do stereo microscopic assessment of the specimen. And it showed the neoplasia so beautifully. So I asked them why it can't be used in real time. And they said, oh, we use, but in stomach, you don't need acetic acid. Indigo Carmine does. So when I came back in 2006, back to England, I started using acetic acid in Barrett's.
Hmm.
And we had great results because those days, the resolution of scope was poor. We were
Much
using
poorer.
standard
Yeah,
definition
you're right.
endoscopes.
Yeah, much
So
poorer.
acetic acid just changed and transformed my practice completely. And that's how my interest began. So then after many years of using, we developed the classification for using acetic acid called PREDICT, where basically it's based on two things. One is loss of aceto-whitening or the appearance of focal redness. And the second is the pit pattern.
Can you tell us what is the mechanism behind the acetic acid? How does it work?
Perfect. So basically, when you spray acetic acid into Barrett's, what happens is the protein in the cells gets reversibly, it's a reversible reaction, but the proteins get acetylated. And then very quickly, this acetylation reverses. And what happens is when patients develop dysplasia or cancer, the nuclear cytoplasmic ratio changes. Nuclear becomes bigger, cytoplasm shrinks, so there's less protein. So the malignant cells, the dysplastic cells, they lose acetic acid very quickly and they become red. Whereas normal Barrett still stays white for a long time. So we try to time it, and we publish data on that, that if you lose aceto-whitening within 60 seconds, then highly likely that you have neoplasia.
This is or dysplasia.
Yeah, or dysplasia.
So once you make the diagnosis and you see a very flat lesion with the minimal mucosal changes, you have a dysplasia. What is your first approach? You go resection, you just burn it? So
that's very good. For years, the management of Barrett's neoplasia has evolved over the years. As options, more and more options came along, and endoscopy skills began to improve and change. So the way we work in Portsmouth is, if it's completely flat and almost invisible, so if you can't see endoscopically, which is rare, but if you are in that situation, then we would go straight for ablation. Now you can debate whether you want to go for RFA ablation or APC ablation. However, if you have a visible lesion, we always resect. Now, if you have a visible lesion, which is really flat, 2A, small lesion, less than 2 centimeter in size, we would go for EMR. However, if you have a nodular lesion or anything which is bigger than 2 centimeter, we go for ESD. Now, we have a good data on that. By doing this, you tend to select all the cancers which get resected by ESD, and you select dysplasia which get resected by EMR.
So you mentioned before about ablation. So you've been working also in the space of ablation, and you have done a couple of nice papers on that. How did you move from the concept of radiofrequency ablation, RFA, to hybrid APC? What was the reason for moving to another technology?
I think when RFA came along, this was, it looked revolutionary, because you had...
It was revolutionary at that time. No?
Yeah, it did change the management of Barrett's in a big way. It's one balloon, you inflate, you press a button, it burns, and Barrett's disappears. However, in real life, when we treat patients, what we find is not every patient has a straight esophagus. The balloon doesn't always have good contact everywhere. So there are lots of skip areas. And in some patients, after ablation, they just don't heal. Barrett's doesn't disappear, although it's ablated, but poor healing doesn't disappear. Or there are patients who find RFA ablation very painful. I've got quite a few patients who don't want to have ablation again because it was so
because of pain?
Pain. It can be very painful. So there's a whole range, and then also you need to factor in cost. So if you want to achieve complete ablation of Barrett's...
That was a big issue of your study, no?
It was, absolutely. If you want to achieve complete ablation, on an average, you need about 4 to 5 sessions of RFA ablation. And that's pretty expensive. So what we do now is, in our study where we compared RFA ablation with APC ablation, at 1 year, we did not find any significant difference between the resolution of neoplasia in both arms, but there was a massive difference in the cost. Obviously, APC was a lot cheaper than RFA. But I have to say that the study wasn't fully powered to show the difference in neoplasia eradication rate. We did 100 patients, which I think is a good size study, and we did not show any difference in neoplasia eradication rate. But since then, we have adopted a very practical approach. So if we have a patient who has, say, 2-3 centimeter of Barrett's, it's very quick for me to do APC ablation in sedation.
Yeah, but I might ask you a point. So we didn't use APC in the past for Barrett because we were concerned about the results, and now we have a hybrid APC. That was one of the reasons that convinced you mostly to go ahead with the APC. So the concept of hybrid and elevation should be because of creating space and burning more that was appealing to you.
I think you're right. One of the concern about APC was that if we use APC, doctors inherently, we are risk averse. So people were under-treating the Barrett's. When you under-treat, you were getting superficial squamous island and there was buried Barrett's underneath. And there was worry that you can get buried cancers, buried Barrett's. If you ablate too much, you're worried you'll cause perforation or stricture and problems. And that's the problem was resolved with hybrid APC, because you inject, you have a good cushion, and that gives you good confidence to crank up the APC power and really ablate properly.
Which power you're going to use with the hybrid APC for Barrett?
So I use 50 watts at pulsed APC at 50. And we use a cap in front of our gastroscope, get the catheter out just out of the cap. So that gives enough distance between.
So you don't move the catheter, you move the scope. No, you have a fixed position of this device and move the scope, no?
Yeah, so the catheter, the cap, and the scope, they all become one part. And we then just use the torquing movement and paint the esophagus with it.
So tell us about the technique. You start focusing on a specific area, you elevate that specific area, you burn, and you move to another area, or you elevate the entire Barrett surface and afterwards you go to ablation?
That's a very good point. I've seen some people doing almost injection of the entire Barrett's and then just ablating. However, I found in my experience that inject, ablate. It works.
This is also I love. Yeah.
And it works very well. It also allows you to have that freedom that today we will only treat this much. Patient is now not tolerating. So I treat sector by sector.
And also, this gives us a lot of control. I never see skip lesions or skips area because I go back with the scope and keep burning. Is that correct?
Absolutely. That was our main reason for switching from RFA to this, was because we can target every single area, irrespective of the shape of the esophagus. And that just gave such a good outcome. So now we use combination. We use RFA and we use APC, depending on, so very long segment of Barrett's will give one session of 360 APC, and then we bring the patient back. Subsequently, we just
sort of second step.
Yeah.
At the point you use APC?
Yes. So first session is 360 RFA. Say you have 10 centimeter Barrett's. We do one session of RFA. Next session, we bring the patient back, and whatever is left behind, we treat it with APC. And
okay, with this combination approach, what is the results in your practice with your patients?
I can tell you my unit manager is very happy because I'm not spending so much money. The results, our ablation rate is very good. And slowly, because of pain and discomfort related to RFA, we had started asking for more and more propofol and GA. But because we now started using APC a lot, we don't need that. So logistically, it's become easier, achieving similar or sometimes even better outcome for a very low price.
On this matter, I have a last point. What about stricture and risk of recurrence after APC?
Well, every ablation technique carries a small risk of recurrence. But in my experience, I think risk of recurrence is more related to the resection that you've done before ablation rather than ablation alone.
Okay.
And I know that there's already evidence building up that the RFA, the 360 catheter, the new one, resulted in higher rate of stricture. And that could be related to the fact that it is, it achieves really good contact, gives a very deep burn, and is causing more stricture. With APC, I don't know, Ali, my stricture rate with APC is phenomenally low. I can't remember the last patient I had stricture with APC.
Very good point.
Yeah.
Very
so
good point.
I think APC stricture is very low. I still think ablation and stricture is less likely, but it's your resection before ablation which causes more stricture.
Pradeep, can you remember in the last 3 years after starting with the hybrid APC, any single patients with the barrier glands after below squamous epithelium?
No.
Zero?
Not at all.
Because
No.
you're taking biopsies all the time
Yes,
in
yes,
every
yes.
resected or ablated areas, no?
Yeah, we follow them regularly. We biopsy. I can't
So
remember.
this is not an issue any longer.
I don't think so.
Oh, very good.
I don't think, and I don't think we need to worry too much about that.
Okay, very good point. So we're talking about hybrid technology, and you know I'm in love with the hybrid knife as well. So and you know there is a new generation of hybrid knives coming. I think you have seen a couple of videos and drawings. And what is your feeling with that?
I'm really, really excited and looking forward to that. I use hybrid knife also in my practice, but mainly to do poem. I use it for poem, I use it for G poem, and then if I'm doing a rectal lesion, I would use it. The beauty of hybrid knife is the injection that you get. The speed of ESD really goes up. But I'm very old fashioned, Ali. I train with these small 2 millimeter, 1.5 millimeter knives. So this long blade of traditional hybrid knife scares me to use it for ESD anywhere other than rectum. So looking at the new knife, I was really excited because although I don't know all the details and you should clarify, my understanding is the injection power will remain the same. So
Absolutely.
we'll have beautiful injection, but the knife goes down to 2 millimeter. And that, if that is true, that will transform my practice.
So yeah, I had the privilege to test in an animal study altogether with Horst Neuhaus and Jeremy Jack from France, the new device, and so the new device is smaller, and the blade is thinner, and the tip is a little bit rounded like a dual knife, but you still have the same capability of injecting. So pressure of water is exactly the same. And what we have seen, what we have appreciated, that the cut is much better. So you don't see a lot of coagulation effect on the tissue. You know, all the whitish part on the mucosa or little burning on the submucosa. And we were all very happy about the test that we've done in animals. I do believe that Erbe is bringing this into the market quite soon, probably by the end of the year, they should get the CE mark. So this is going to be a big innovation in ESD practice as well, because we are aiming to have in ESD practice a needle that allows us to be very precise but still injecting water, no?
Beautiful. I completely agree. I mean, if the knife becomes very precise with very little collateral damage, the size goes down, but the capability of injection remains the same, it will transform practice because ESD will become very safe. At the same time, efficiency and speed of
It's
ESD is very
important.
important. And that's one of the big reasons why ESD has not taken up so well in the West, because most of the Western colleagues are not as fast as our Japanese and Chinese colleagues. I know that you are an exception, but
No,
if
no,
you
no,
look
no.
at a majority of the people, ESD takes much longer. So whatever we can do to improve the efficiency in ESD
And
will
safety, and
help.
safety as well. I think safety,
Yeah,
because big
absolutely.
cushion and the possibility of keep injecting when you are in trouble and seeing better symptoms is
It's
big
very
advantage for
important.
us.
Yeah, yeah.
So, Pradeep, thanks for your time. Tomorrow you're coming to Milano, no? It's
Absolutely.
now your second house. You come in Milano regular basis. So we have organized everything for you. Thanks
Perfect.
for joining us for Endoscopy on Air. And I think we can say that you probably will be doing an ESD case, my case. I'm giving you my case. So it's a privilege to have you here doing our case.
Pleasure.
But
Uh,
thanks.
I
Thanks,
can't
Pradeep.
wait.
Thanks so much. Thanks
Ah.
so much.